learned audience and participants. Sometimes in the cath lab, we are in so horrible condition, we forget the name of my wife, name of my father. And it is one of that case. Ghost in left main. I think this can be seen very well. Are you seeing? Are you seeing faculties?
Can you make it maximize? Can you maximize the screen?
This is the maximized, no more. And you are seeing something in the left main in a coiled fashion. Are you seeing, Dr. Mahbub?
Yes, yes.
Okay. Let us see a simple case, 50 years male, diabetic, hypertensive, and is on medication, having chest pain on exertion, CCS 3, class 3 angina, history of unstable angina 1 month back, and blood pressure is normal, no COVID infection. Definitely we do it before the procedure, and ECG, left ventricular hypertrophy, echocardiography revealed good LV and RV function, ejection fraction 60%, and diagnosis is now unstable angina, hypertension, DM. And this is the angiogram. Are you seeing the angiogram clearly? The
Yes,
panels.
but the screen is very short. View is very short. Can you?
Our screen
Yeah,
is
we can
bigger.
we
If
can
you
see,
see
but I can
in
see.
your laptop, then you will see the bigger one.
Yes, I'm
Yes,
using the
yes.
left one. I'm
Uh,
not.
You have to, I think, Mahbub bhai, you can double click over the screen, that will come bigger.
Double click করলাম তাও আসে না কপাল
But
খারাপ
I can see in full screen. I can see the full
এটা তো
screen.
ওই
মাহবুব, তোমার আপনার কপাল খারাপ না, কপাল আমার খারাপ যে আপনার কপাল দেখাতে পারতেছি না।
So anyhow, I can see actually. I can see.
আচ্ছা ঠিকই আছে কপাল হ্যাঁ
Anyway, you see left system and then right system. Okay, Dr. Ashok.
Yes, sir.
Okay. Then our angiographic diagnosis, distal left main, maybe 30,
Oh,
40%
yeah.
apparently with plaque extending the LED most likely. Ostial left circ, 19 to 99% stenosis, RCA normal. And syntax is 2 years, syntax is 17, 18. And so what we should do? Can you tell me the decision from the panels, what we should do? In diagnostic angiography, it looks like critical lesion in the ostial circ and extending just up to the proximal part, and plaque in the distal left main, and apparently LED is healthy. And the patient is typically symptomatic. He can't walk few steps. What should we do? Whether keep him on drug treatment, or we should do medication, some intervention.
If the patient is on maximal medication, I think there is you can take the help of distal left main. It looks like 30-40, but
Yes.
if we assess it by IVAS or by OCT or even by a paper, that can give you the clue whether it is critical or not. Sometimes angiographically, left main may looks 30-40 in on angle. In different angle, it may be 50-60% like this.
Okay, as because the patient is very much symptomatic, we deferred the patient, and after 1 month, once again, every 2-3 days after he talked with us over telephone, sir, severe pain, I can't wait, and I am on a spray. And that is why we called him and entered him in cath lab and do a check angiogram, and this was the findings of the check during angioplasty. And for during this time, I have parked the wire, floppy wire into the LED as well as in the left circumflex, and I am seeing by pull back IVAS from left LED to left main as well as from left circumflex to LM. and the result of IVAS. This is LED pullback, and this is LCX pullback. The longitudinal view was also essential from where to show it. It is shown that a left, no, no, the ostium of the, yes, ostium of the ostium of the left circumflex, ostium of the left circumflex is approximately 90% stenosis, and there is area is 1.3, and distal LM is 4.5, and ostial LED is 4. Then what should we do? Whether we should do only LM to LCX, or we should do first LM to LED, as because there is no significant lesion in LED. So I wanted to do LM to LCX, and then I shall see what is the scenario, and accordingly I shall do. And you see, after pre-dilatation, we have deployed one stent from LM to proximal LCX. And after deployment of the stent, we have post-dilated the stent. And after post-dilatation, there is a haziness or opacity in the LED osteoproximal region. We have post-dilated adequately, and because there is significant haziness as well as narrowing on the right panel, meaning that there is plaque shift as well as some disease in the LED ostium, and that is why I plan to do a KBI only. KBI and then port in the proximal LM. And this is the result. You see the result. We are showing this is the result after KBI, and you see here the LED and pullback from LM to LED. And this pullback also shows the LED ostial 3.1 in the LED ostium, meaning that there is significant narrowing in the LED. And so I plan to do something for LED. As because I have given one stent from LM to LCX, then I thought to give another stent in the fashion of inverse tap to the LED. And stent deployment in LED. This is the result after stent deployment in the LED, and KBI is done. And after KBI, when I wanted to go with a higher size balloon to do the port, this is the scenario. This is the scenario. What is the proximal part of the LM?
Could you please go back to the previous kissing?
Yes. Kissing.
So balloon was extended just beyond the stent proximally in the left main. That was not covered by stent.
No, it was covered with the stent, as because we are, left main is not so big. That is why I have covered ostium of the LED to proximal circ.
Ostium of the left main to proximal
Left,
circ.
sorry, ostium of the left main. And this is KBI.
So how much heparin was given?
Heparin was 10,000 given, and SCT was 400. But this is the scenario. Whenever I have noticed it, something in the left main, and I was entering with a balloon 4 dia, but I could not be able to reach the LM. And then I carefully seen that there is something in the LM, meaning that the deformed in
Stand
the
deformation.
stand deformed in the LM, making it a like ghost shadow.
Yes.
What
So
should I do?
during so that happens when you just pull back the kissing balloon. When you try to pull out the kissing balloon, that time tip of the catheter, I think, make the
Yes.
deformity to the stent.
Yes, that is my also my idea. Stand guide introduced inside the inside the LM, and it made this deformity. And whatever it is, this has occurred, and I am in the cath lab. Patient is in front of you. What should I do now?
So you should definitively take a Newark balloon,
I have
3.5.
I have
Yes,
I
you
have
have to just you have to dilate the left vein. You have to dilate the left vein along the LAD.
only
And if necessary, you have to put another stent to cover the.
And then subsequently
okay.
you may need another stent.
That is the second option. First option, I shall have to inflate
Dilate.
the stand.
Yeah.
And you see, I have pushed one balloon into the LCX and another wire in the LED and one tracked another balloon in the LED, and it is easily crossed. So I am assured that something I should be able to do. And I have to go subsequently with 1.5 millimeter, 1.5 millimeter, 2 millimeter, then 2.5, then 2.3, and then finally with a higher size balloon. You see in the middle,
Oh, no,
you
no,
see in
no.
the middle how you will overcome this situation. Would you pull back the stent by snaring or send the patient to surgeon?
No, sir.
Second
Uh,
step, you may put it.
so just try to predilate, try to dilate the post dilate with new balloon 3.5. Then you can put a
Second,
3.5 or 4 millimeter stent in the left main. That will cover the deformed stent.
And you see
What was the hemodynamics at this point?
hemodynamics is all right. As because TME3 flow is there and sequential dilatation with higher size balloon. And this is the result after post dilatation with sequential balloons and
Without
keeping to some extent alignment with the wall and removing the ghost outside, meaning that in the wall. Next
So there
question
is,
comes whether I shall take another stent or not.
yeah, definitively you should, because many of
exactly.
the part of the left main is uncovered because deformed stent, many
Chances of
part of,
ISR is there.
Yeah.
so there will be increased possibility of ISRs. Moreover,
Yes,
that
yes.
the hanging part of the stent that
Will
may
predispose to
produce thrombus.
thrombosis.
Yes.
Yeah.
So better to
Yes.
cover
With
the
sudden death as well.
How about Jamal bhai? How about IVAS now?
Yes.
Yes, that is important issue, sir.
Yes,
Yes.
exactly.
At this time, I wanted to put, you see, there is some part of the stand when Dr. Ashok marked it very nicely, correctly, that when I pull back both the balloons after doing the final kissing balloon inflation, at that moment, distortion of the stent occurred as well as part of the stent pulled back into the aorta, and it is hanging some part in the hanging in the aorta and rest in the left main to LCX, and that is why it was very difficult to give some strong thing or hard thing through this hanging part, and I could not be able, I could able to inflate it, dilated it, but I could not be able to introduce the IVAS catheter. I could not be able to introduce another stent as
So
because
what?
there is a hanging part. And this hanging part is like a hanging shard. And through this hanging shard, how shall I enter with a hard thing? I have given another wire. Even then, I could not be able to give another stand, or even I could not be able to see by IVAS. But thanks God, up to this, I am happy as because it is well inflated in the left main, though it is hanging in the a bit more hanging in the aorta, but it is well inflated in the LM, keeping the TIMI3 flow in the left circumflex as well as left anterior descending artery, and with good hemodynamics. And so I finished it here.
So how the patient is doing, Jamal bhai?
Yes. 10 days I kept the patient in ward, admitted, and every day I follow up the patient. Patient was all right. And after 3 months, patient came back. There is no chest pain and patient is well. And after 6 months, I shall try to give another check if possible,
Exactly,
as
exactly.
because there is hanging stent in the aorta.
Professor Hafiz sir is here, sir.
Yeah.
So what is your opinion regarding the second stent covering the deformed stent? Number one. Second issue, how there is possibility of ISR. How much possibility? Is it 30-40%? And third
Yes.
issue,
Yeah, go ahead.
third issue regarding the check angiogram. Would you prefer the CT angiogram or conventional angiogram?
Or
No,
MRI, CT
let
MRI.
me tell you
MRI
about
angio.
the CT angio first, because
Yes.
you know, I did this whole chapter with Dr. Narula about CT angiogram in his book. There is a separate kernel to use for evaluation of CT angiogram. You have so many structs, you may not be able to see it because of the blooming artifact. So I think CT and you can see CT angiogram if it is like a 4-0 stent and thin structs. Here we have a lot of mumbo jumbo, and we may not be able to see it very well. And
Yes.
ISR, I congratulate Mir Jamal bhai because you came out nicely. At that point, I'm not thinking about ISR. I'm thinking about something TIMI3 flow,
Yes.
and then patient chest pain free, get the patient off the table and give adequate antiplatelets, and then do a follow-up angiogram, and then think about ISR at that time. And in the meantime, we buy the time for endothelialization. Cardiac MR is not going to be a good thing for this patient. I can tell you that. Now, about the covering, if we cannot do IVAS, then I think we are okay with angiographic picture. The key is if the patient is chest pain free and you have TIMI3 flow and you have this result, I think it's time to quit.
As
But
because
how will this hanging part will be endothelialized? So how can you predict it?
We cannot predict. That's why we need to do the follow-up. You're absolutely right. My main worry and that's why we all need prayers that there is no stent thrombosis.
that's
Yeah. Yeah.
So to me, there is some take-home message that treatment decision should depend on each patient and each lesion. You see only preferably on angiographically a simple only LCX osteal lesion. We always avoid osteal LAD LCX lesion if there is no significant lesion in osteal LAD or distal LM. We try to avoid. We try to keep it in with medication. And my mentor, Dr. N.M. Jamal, he told that আমি দোয়া করি আপনি এই আপনার এই লেফট সার্কামপ্লেক্সটা বন্ধ হয়ে যাক আস্তে আস্তে, যাতে আপনি হার্ট অ্যাটাকও হলো না, আপনি বেঁচে গেলেন।
Sir, just I can just share one of my patient. He is a doctor. 4 months back, I did the angiogram. Similarly, LCX osteum was so tight, but left main is quite normal. LAD is quite normal. Again, last week in the COVID, he admitted with chest pain. Troponin I was mildly raised. This time he was just asking and sometimes forcing me to put the stent. But anyhow, I gave him 10 doses of enoxaparin. Then after symptom free, I discharged him. So what should I do for this patient? I think he will come back again maybe 2-3 months after getting another episode of chest pain. So should I do for this patient, sir?
We should not touch this circumflex. And there in course of time, there may be some collateral vessels.
No.
Yeah, Dr. Mahbub,
Doctor-
Dr. Mahbub, yeah, this is a 001 in the left main. 001 in the left main means that sometimes even in EBC 15, sometimes you have to intervene it. It doesn't mean that one complication doesn't mean that you shouldn't, because if the LCH is more than 2.75 diameter or more than 20% of the myocardium is supplied by the LCH, you have to go for it.
The other thing
So you will do left main
Okay, but what do you
circumflex
say?
PCI for this.
No,
Yeah,
circumflex.
also let me, because 001, this is 001, it's a bifurcation lesion, and 001 you have to, because it's an osteo and osteoproximal lesion in the LCX, and LCX you shouldn't underestimate the LCX, just hoping that it will be slowly it will be progressed to a stenosis. By that time there will be some collaterals. You can't wait for that one.
I'm
So
not
anyhow,
underestimating, but this is a non-dominant circumflex, and
No, that's not good.
But still it's
That was
supply.
the code
it's
of an
supply.
And what about
My patient
Professor
has put
Saidur?
it- But on here
Professor
is
Saidur, what about
yes, what
evidence-
Habib's Bhai is saying about this?
so this patient may develop arrhythmia and there is chance of sudden death, isn't?
Yeah, that's why I'm telling. LCX, it's really dangerous because it's like, you know, that hiding monster.
Professor Rahman, have you seen my case?
Yes.
What could I do? What else could I do?
Now, after doing all these things, after finishing with this mess, you have nothing to do else.
Now,
You have to live in that way.
very beginning,
Exactly.
whenever I have seen that there is this
Exactly.
ghost shadow in the left main hanging some outside, what should I?
What you have done, that is the perfect one, because that is the last resort you have. There was nothing to,
Yes.
we have nothing to do
Well,
there in the left main. If it
Thanks
is in the
God,
distal LAD
now-
or in the middle LAD, then we can do lots of things
Yes.
there, but it's left
So
main.
I-
So when there is TB3 flow, then you should quit as early as possible, even from the hospital, so that you are safe.
and
So,
thanks
Professor-
God.
Yeah,
Thanks God,
maybe
my
Jamal
both the
Bhai,
wires were in
if
situ.
you could not establish the flow in the LAD and circumflex, and then I would say that with putting this IEBP will send the patient to surgery. That is
Yeah,
the
you
last
have to
option.
stand it. Then you have nothing to do there.
And may require emergency CABG.
Yes,
Yeah.
right.
Yeah.
And in bifurcation
Jamal Bhai, I want
Yes.
to, this is Dr. Safiuddin, I want to make a
Huh.
comment. Can we think in a different way? The cause you shown, that is all right, and you managed successfully, we are happy. But is it possible that when you rewired the LED, LM to LED, then the wire can outside the start?
Even I have shown, even then, this outside hanging within this, মানে বাংলায় যদি বলি যে একটা স্ট্যান্ড থেতলায় গেছে, কুচকায় গেছে, সেই কুচকানোর ভিতর দিয়েও ওয়্যার ক্রস করেছি এবং বেলুন ক্রস করেছি এবং বোথ এলইডি তে গেছি, বোথ এলসিএক্স এ গেছি এবং এলএম এর ভিতরে স্ট্যান্ডটাকে ইনফ্লেক্ট করেছি।
I think Professor
This
Mir-
wire went through the whole length or it's a partial?
এটা শেষ
এলএম এলএম
LM
জামাল
partial.
জামাল ভাই,
হ্যাঁ
আচ্ছা একেবারে প্রথমে যদি আবার ব্যাক করি আর কি, মানে আপনার যে
হ্যাঁ,
প্রথম যে বেসলাইন
হ্যাঁ,
অ্যানজিওগ্রাম,
ডক্টর মাহবুব, হ্যাঁ
না ওয়ালি বলছি জামাল ভাই।
ওয়ালি, হ্যাঁ বলুন।
আচ্ছা, নাইস প্রেজেন্টেশন এন্ড নাইস বেল আউট, বাট আমার কোশ্চেন হচ্ছে যে আপনার একেবারে শুরুতে যে অ্যানজিওগ্রাম যেটা দেখা গেল যে হোস্ট
হ্যাঁ।
ইফেক্ট আপনার ইয়েতে সার্কামফ্লেক্সের অস্টিয়ামাস, ইউ নো দ্যাট
এলএম, ওটা এলএম এ।
এলএমএ আর কি, হ্যাঁ। এবং
Post LMA।
পরে যে ঝামেলাটা হলো সার্কামফ্লেক্স অলওয়েজ ন্যাস্টি প্লেস, মানে ফর এনি সোর্স অফ মানে আপনার স্টেনোসিস অর আইএসআর অর থ্রম্বোসিস। সো এটাকে আমরা ওই সময় কি আপনি পেশেন্টকে কি করেছিলেন যে যখন বাসায় পাঠিয়ে দিলেন সেই সময় কি টিকাগ্রিলর অর এরকম
হ্যাঁ,
কোনো পেয়েছিল কিনা?
না তা তো আমরা ডেফিনেটলি এমনিও এখন রুটিনলি সব পেশেন্টকে অ্যাসপিরিন টিকা গ্রিলোড দেই। নাও ইট ইজ ক্লোপিডিগ্রল, ইব্রাহিম কার্ডিয়াক
Sabina,
সেন্টার যে
thank you,
রিসার্চ
Dr.
আছে।
Bidul.
এবং হাউ ওল্ড দ্য পেশেন্ট ইজ নাও? পেশেন্ট
বাই দিস 3 months হি ইজ ফাইন, দ্যার ইজ নো
না এজ কত জামাল ভাই?
So,
is 50 and he is
আচ্ছা,
walking
যেটা
daily 1.5 miles.
so Professor Mir
So
Jamaluddin-
Prasural would have been better than ticagrelor.
Is
in
there
this
any
stage.
superiority of
Uh,
prasugrel over
if it's
No,
over
if it's not
ticagrelor?
not an ACS setting, then you can't say that prasugrel is superior to ticagrelor. If it is an ACS setting, then you can tell that yeah, prasugrel a bit preferable to ticagrelor.
Is it? Is it? In acute
So-
coronary syndrome,
Right.
we shall choose ticagrelor or prasugrel. If
Yeah.
not available, then clopidogrel. This is the
Usually, ideally, is
Yeah,
the
ticagrelor
and prasugrel are all are same effect almost.
all are
Yeah.
but
same.
ESC
Yeah,
guideline নতুন যেটা
Professor
বলে
Jamal
সেটাতে আপনার
Uddin.
prasugrel is superior than
Yeah, that's I'm
ticagrelor.
telling. If it is an ACS setting, then prasugrel is
Yeah.
preferable to ticagrelor.
Yeah,
They're
yeah.
telling.
Thank you,
Yeah.
Professor
Guidelines are
Jamal
telling, all
Uddin.
the trials
Yeah.
are
Professor
telling.
Mir
Prasugrel
Jamal
is
Uddin.
for ACS
Yes.
setting, right?
Yeah.
What I want to say in my observation, you are also lucky and your patient also lucky. Thank you very
Yeah,
much.
definitely.
And another thing is that Dr. Ashok,
Next.
only LCX ostium cannot be involved. If the
Yes.
ostium of the sarc is involved, there is definitely plaque in the distal left main. If there is ostial LA deletion, there is definitely plaque in the LM.
I
Though
agree.
it may
Yeah.
be not significant. Whenever we do
agree.
IVAS, only then we can tell.
Yeah,
Yes,
yeah.
that is
You,
Agreed.
Professor Mir
Approximately
Jamal Uddin.
70% cases there is
Professor-
involvement of the
Professor Mir Jamal
yes.
Uddin.
ফজলু ভাই একটা কথা বলি
What I want to say, if there is osteal lesion of LAD or LCX,
70%.
whatever may be, it is the part of the left main disease.
Yes.
About-
Agreed.
And somebody told that whenever I treat LAD ostium, I treat distal left main.
Yes, yes, that is why. That is why.
Meaning
That is
that
not
if
the
you
thumb rule
do
all the
the
time. That
IVAS,
is not the
you
thumb
will
rule all
see
the time.
approximately in 70% cases there is involvement of
Most of
distal
the
left
cases, yes, correct.
Thank you very much.
Thank
Thank
you
you
all.
very much. Next.
ফজলু ভাই একটা কথা বলি মানে উইল বি
Yes.
লাকি ইফ দিস পেশেন্ট নট কাম টু আস
main.
Thank you, sir.